go. So I won't go more than this slide. This will be the last slide. Thyroid disease 2. Although there was supposed to be thyroid disease 3 and 4, I've cut them away because I want you to have a rest, but we'll do them in the drills. Well, if you see a patient in the AKT with hyperthyroidism, I've told you to refer. But in the AKT, they can basically start to talk about hyperthyroidism in different ways. What are the causes of hyperthyroidism in the AKT? By the way, I forgot to list the causes of hypothyroidism in the AKT. I told you the commonest is Hashimoto's. I told you that postpartum thyroiditis has both a hypo and a hyper component. The other medication I've not mentioned to you, which is super high yield, is lithium. If any of you feels a question on lithium, don't phone me. Just keep to yourself. Even if you pass the AKT, don't tell me. Pretend as if you didn't feel the question on lithium. Because lithium is something that you cannot fail in the exam. Lithium, think diabetes insipidus. It is the cause of your nephrogenic diabetes insipidus. Have we not talked about lithium monitoring here? I said it's LUT. Lithium levels, use an thyroid function test. There is nothing we have not said about lithium, and I'll continue to say lithium. Lithium is a mood stabilizer. Lithium is a mood stabilizer. So where do you see lithium? You see it in endocrinology when we are talking about diabetes insipidus. You see lithium in psychiatry when we are talking about mood stabilizers. By the way, your other mood stabilizer will be sodium valproate. You need to know everything about it. You need to be good. Well, lithium is a cause of hypothyroidism. Don't fail it in the exam. Lithium is a cause of hypothyroidism. Please don't fail it. Well, the other cause of hypothyroidism, I've told you, amiodarone has got the two components. It causes hypo and hyper. Iodine deficiency is the commonest cause of hypothyroidism in the developing countries. Don't fail it. Don't fail it in the exam. Well, if you did not know that steroids is a cause of hypothyroidism, that's why I want to teach you tomorrow. Steroids is high yield. That's why I want you to know everything about steroids. I want you to know the 360 degrees. There are about 60 points related to steroids, and you should know most of it. Basically on steroids, they can drive you crazy. If they want to drive you crazy, tell them you have their antidote. Give them their antidote. Their antidote is knowledge about steroids, my friends. So steroid is a cause of hypothyroidism. And if you know that steroid is a cause of hypothyroidism, then why don't you know that androgens and progesterone are causes of hypothyroidism? Don't fail them. Don't fail them. Testosterone, hypothyroidism. Androgens, hypothyroidism. Progesterone, estrogen, hypothyroidism. Don't fail any of this in the exam. Sorry, estrogen is going to be hyperthyroidism. I've just remembered. So let me say that again. Androgen progesterone, AP, is to hypothyroidism, as your testosterone estrogen is to hyperthyroidism. Please correct that. Okay, so let's move on. I just thought I'll list the common causes of hypothyroidism, so that at least you have that at your fingertips, and then you can now dive into the topics and dissect them. Enjoy them like you are dissecting chicken that has been well grilled. My friends, if you go to hyperthyroidism, they can hit you anywhere. Sometimes they want to hit you below the belt. Say no, prevent it. It's very painful. Well, what are the kind of questions? I've told you one, don't treat. It is a real problem. It's a GMC wahala, or it's a reason to lose one mark in your AKT. Don't treat hyperthyroidism. Just leave. Refer. So let's talk about treatment. Let's talk about hyperthyroidism a bit. Now that I've told you about Plumer's disease, which is toxic multinodular goiter. I've told you the difference between it and Graves'. I've not come to thyroid cancer yet. I've not spoken about thyroid storm. All these things will be linked to your hyperthyroidism. But let me just quickly talk about the management because I won't have any time. Carbimazole agranulocytosis for someone that was sleeping. I've just said it the second time. Clozapine agranulocytosis, carbimazole agranulocytosis. There are two regimens, two ways to treat patients with carbimazole. There's the block and replace, and there's the one that you continue just to run it until the patient becomes euthyroid. So let's talk about it. So the other one is the titration block method. Let me just talk about the block and replace. What you do is you give the patient carbimazole continuously for 6 to 9 months. Usually you start the patient at 40 milligrams. It's safer. So they can ask you in the AKT, at what dose do you want to start your carbimazole when you are doing block and replace? 40. Allow the patient to be on it for minimum of 6 months and a maximum of 9 months. By that time, carbimazole would have destroyed all the hyperthyroid problems by destroying those vessels, the nodules, the areas that are producing too much thyroid hormone. Then you start to replace it. So once the patient is euthyroid, after using carbimazole, you replace with levothyroxine. Some patients like it, some don't like it. Some area, this is the only thing they do. They do block and replace. Well, someone may have not heard that very well. I'll just repeat block and replace. 3 points only if you are writing. Someone has written block and replace and has written 3 lines. Don't do that. It's 1 line. Block and replace, point 1, 6 to 9 months. Point 2, 40 milligrams start dose. Point 3, after the patient has become euthyroid, replace with levothyroxine. So if I were you, I can even use half a page. I'll write B and R, or block and replace, 6 to 9 months, 40 milligrams, levothyroxine afterward, full stop. That's half a line. Don't write what you cannot read. It's not fair to yourself. Well, let's talk about the other method, which is the titration block method. What the doctor does here is to start the patient on carbimazole and slowly decrease it. That's the word titration. Start the patient on carbimazole. Once they start to take it and they start to become euthyroid, you start to slowly decrease the dose and until you reach a point where you can maintain the levels. That is titration block method. How long does it go for? Well, your block and replace is for 6 to 9 months, but your titration block method is for 12 to 18 months. Clincher. They say a patient has started a treatment with carbimazole and is on his 14th month. What are you doing? The answer is titration block method. It can never be, because if you can't do carbimazole, using carbimazole for block and replace for 18 months, the patient, you've damaged the patient's thyroid gland. Well, I just thought I should tell you about carbimazole. Well, usually carbimazole will get the patient euthyroid in a short time, but you need to be monitoring the levels, and all these things will be done in the hospital by the endocrinology nurse specialist. Then a question can come: what is the normal time frame for which someone on carbimazole will get normal thyroid function? I know I've said use it for 6 to 9 months before you replace. The answer is 4 to 8 weeks, 2 months. If they ask you a question, a patient has been put on carbimazole and his thyroid function has become normal, what will be the time frame for that patient to notice normal thyroid function things? Is 8 weeks, 2 months maximum, 4 weeks, 1 month minimum. Don't fail the question in the AKT. Well, I've told you about carbimazole. Can I talk about propylthiouracil? It's similar to carbimazole, but it has a bigger risk of hepatic problems, so liver problems. Well, if one of them is going to cause death, is propylthiouracil. Why do you think it has been relegated to second line? It's more problematic. And well, even if it's not more problematic, when it starts to bring its complications are life-threatening, hepatic failure. So, my friends, propylthiouracil is no longer very common. It's used when we cannot use carbimazole, and it's relegated to second line. Of course, all of you now know that radioactive iodine is third line. Nobody wants to use it again. But if you want to know a bit about it, what they do is to drop a cube of radioactive iodine in water. It dissolves and the person drinks. It's like he's taking a cup of Coca-Cola, or it's taking some apple drink. So they just dissolve it and they just enjoy it. but it causes so many problems. The problems are too much. It destroys the thyroid gland or thyroid cells in a way that sometimes you don't expect. It makes the patient euthyroid and causes the patient to have many other problems. But again, it's still on the guideline and it's third line. Please ensure that any of the patient you are trying to do this treatment for is not pregnant. If she's pregnant, please, first of all, let the specialist be the one. Let the specialist be the one to initiate the treatment. Know when carbimazole is teratogenic. Know when propylthiouracil is teratogenic. Okay, I just thought I would just talk a bit about the management because I won't have time to come back to the management. So I just thought I would just say it now. So now that I've said the management, I think I'm a bit happier. Let me go to the main other things that we need to talk about. So I've talked about hypothyroidism. I've told you a bit about Hashimoto's, which is the commonest one. I've told you about the causes, and you already know the picture. So let's leave that. Thyroid storm. Thyroid storm in the AKT is rare. It's a rare presentation, but the only reason why we are talking about it today is deadly. Is deadly. If you don't quickly treat the patient can pass on. How does it present? Fever. A patient with thyrotoxic crisis, which is thyroid storm, will come in with tachycardia. They'll come in with fever. They'll come with altered sensation, altered mental. So their GCS will be reduced. That's what I was trying to say. They may come in with delirium. If you see this patient, don't start chatting with the patient in the GP practice saying, can I quickly take some history for 15 minutes before I know what to do? What are you doing? That's a GMC problem, my friend. For that patient, call the ambulance. I've told you two reasons to call the ambulance. Addison's crisis. Call the ambulance. Sick day rules. If the patient is vomiting, call the ambulance. This is another reason to call the ambulance, my friends. A patient that you have just seen, the patient is having fever. You know the patient is known to have thyroid disease. The patient is suddenly having fever. The patient is having tachycardia. That's not a problem. The problem is the reduced GCS and you want to take history. The problem is the delirium and you want to take history. My friend, the GMC will write to you. And you don't want that. You are still too early in your career for the GMCs to be writing to you for clarification. You are going to cause yourself unnecessary anxiety, my friends. So what do? Say, this is not my job. This is not my duty. Refer to A&E. Call the ambulance on behalf of the patient. So what will happen in A&E is that they will admit that patient and start supportive care. If the patient needs fluid, they will give fluid. If the patient needs AF management, they will give beta blocker and all of that. I just thought I should chip that in because whenever we go to the drills, I won't. There are some things I won't touch at all. They are not super high yield. That drills is for high yield stuff. So I've left some things out because I just want you to really know them. Well, let's move on to thyroid cancer. Is FMAP. FMAP. If you don't know what FMAP is, I will spell FMAP to you now. FMAP is follicular. That's the F in the map. The M there is medullary. The A is anaplastic. And the P is papillary. Well, again, because of our time, I know it's almost 11, even if it's not past 11 now. So let me just run my mouth for 30 seconds. Only 4 things I want you to know, or 3 things. 1, know the types of thyroid cancer. Riedl's disease is not thyroid cancer. Let me talk about Riedl's before I come into thyroid cancer. Sorry, it popped into my head now that I remembered follicular. Riedl's, how does it come in the AKT? There is a painless thyroid mass. So I've not put it on my screen, but someone can basically rearrange my slide and put causes of painless thyroid mass, or what we call painless goiter. 1, Hashimoto's. 2, postpartum thyroiditis. 3, Graves' disease. And now 4, Riedl's. They are causes of painless goiter. The only one I put on my screen is causes of painful, and I told you 2 of them. So Riedl's is a cause of painless goiter, but it is unique. What do I mean? I've told you that the goiter in Graves is rubbery, is slippery. The one in Hashimoto's is the same, is firm, rubbery. But the one in Riddle's is hard. It's like wood. If you are touching wood, if you are touching a hard surface, if you are touching the floor, that is how Riddle's is. Riddle's is hard, is fixed, but it's painless goiter. Let me go back again. The picture of Riddle's is a hard, fixed, painless goiter plus a hypothyroid picture. Is one of the causes of hypothyroidism. I didn't mention it. There are things I didn't just want to go into. It will just keep us here till 1 p.m. and I don't want to. That's not my intention. So Riddle's disease, hard, fixed, painless goiter plus hypothyroid picture is Riddle's. Somebody is saying this information is too much. That's why you have to come for the drill, because it's in the drill we'll break it down and repeat it. You will repeat it because I don't talk in the drill. I ask questions in the drill. You talk in the drill. So that's the only place you can know it. When you see your colleagues saying it, you know that you can say it. When you see your colleagues getting the answer, you know you can get the answer. You need to come to the drill, my friends. Okay, fine. So I've told you about Riddle's. And why did I remember Riddle's? Because cancer of the thyroid behaves like Riddle. What do I mean? It is also hard, fixed, and painless. The only difference is that it will not give you a hypothyroid picture. It will come with weight loss. So if you are seeing a patient who has weight loss and has a picture that looks like Riddle's, it is a thyroid cancer, my friend. That's point 2. Point 1 is FMAP, follicular, medullary, anaplastic, papillary. 1. Point 2 is the kind of goiter, hard, fixed, and painless. How do you feel it? Well, let me tell you point 3. If you don't know point 3, point 3 is that follicular. No, point 3 is that anaplastic is the most dangerous, while papillary is the commonest. I was almost mixing it up. So, but yes, I'm sure of it. Follicular is a nice guy. Follicular and medullary, they are nice guys in terms of cancers. Anaplastic is virulent. Anaplastic is dangerous. Anaplastic is wicked. Anaplastic will be the one that will kill a patient in 6 months. But the commonest is not anaplastic. The virulent one is the least common. The commonest one will be papillary. If you see patients with thyroid cancer and there are 10 of them, 7 of them will have papillary. In fact, if you check, it's on NICE guideline, it's 80%. That's the number they use. 80% will have papillary. Another way to know papillary is that it has something called Salmonella bodies. Salmonella bodies, think papillary. Why did I bring it out? Because papillary is the commonest and they may want to ask you a question on it. The only other question they can ask you is they can use Salmonella bodies to try and displace you. With that, you know that they are talking about papillary. How do you feel these things in the exam? So, my friends, I don't want to go too deep. I've
Are
given
you
you 4
happy to
points to
say
play
those
around with.
things again, please?
Yes, I'll say them. Follicular is the medullary. Please, when you hear medullary, think about your men 1, men 2A, men 2B. I'll go over it tomorrow. But medullary and follicular, they are nice guys. That's FM in FMAP. Anaplastic, I deliberately left A and P to be last in the acronym. I made this acronym so that you can know that anaplastic is dangerous and papillary is commonest. FMAP. You get the notes, you get your notes. So you see it, but I just want you to listen. I just want you to hear it. I want you that when you are hearing for the second time or when you are saying it, it sticks forever. For me, that I was just trying to remember anaplastic. It just came back that remember that anaplastic is the bad guy. I say, okay, yes. Anam is the bad guy. Anam is the bad guy. Papillary is the popular guy. P for P. Remember that papillary is the That's how I remembered. I remember that the last 2 are the ones that have significant importance. And I wanted to say, well, is it follicular? I said, no, it's the last 2. Then I wanted to say, is it anaplastic that is more virulent? I remember that P for P. Papillary is the popular guy and Anam is the bad boy. How do you feel these things when we play around with it? When we watch it like a movie in the cinema? When we eat it like chicken and you are eating chips with ketchup, how do you feel it? Enjoy it, my friends. Relax and enjoy. If you are reading in a hot room, don't do that. Go to the beach side, get your audio books, listen to it, and have just a small tablet and enjoy yourself. You can read on holidays. You can read by the beach side. When you close from work, if you stay near a city that has got a nice, lovely beach, drive there, sit down there and study. The studying is better. Studying is better when you are enjoying it. If you force studying, you will not remember. I can promise you the AKT will make all those details fly away from your head. So enjoy it. If you enjoy it, you become good. Okay, so that's thyroid cancers for you. Any other thing about thyroid cancer, we'll talk about it in the drills. Thyroid eye disease, I didn't even know it was on the slide. I basically ran you through thyroid eye disease. I've told you that the TSH receptor antibodies in the eye is the one causing collagens to be filled behind the eye and is the one pushing the eye outward. Well, I still have so many things to do today. I have too many things to talk about today. I feel sad that I've not scratched some of the areas that I wanted to scratch by running my mouth. But I'm happy that I was able to do a bit. We'll continue this because we're not going to do thyroid tomorrow. We have too many things to do, and tomorrow is shorter than today. We'll never pass 10 o'clock. So usually, because people are going to church tomorrow, we want to stop at 9:30 or a few minutes to 10. So tomorrow is heavy. Tomorrow is diabetes. Diabetes alone is 2 hours. If I look at how tomorrow is, I see that it's not going to work out. I do only diabetes. I move every other thing to the drills. You can't fail a question on diabetes. How do they ask a question on MODY and you don't know sulfonylureas is the answer? Well, there's this a candidate here that doesn't know the classes of sulfonylureas. It's first generation, second generation, third generation. Glibenclamide is the first generation. Glimepiride is the second generation. Gliclazide, which is very common in the UK, is the third generation. If you go to the US, they are still using glibenclamide everywhere. Sulfonylureas, the problem is it's an oral hypoglycemic drug. Some patients will collapse. They don't like it. They collapse because of hypoglycemia. By the way, you need to know the threshold HbA1c if you are starting an oral hypoglycemic drug is 53. If the patient is going on two medication, what's the threshold? When do I know that which HbA1c will I see before I start the patient on the second medication? It's 58. They turn up in your AKT. They will greet you. They will smile at you, knowing that you may not know. But when you smile back at them, they will be disappointed. This is how to smile back at them. Use your knowledge to smile. In the AKT, the candidate is moving very quickly. He has reached number 60 within 20-30 minutes. Is knowledge. Is only knowledge. Knowledge guarantees speed, my friends. So tomorrow we'll talk about MODY. I won't talk too much about LADA. It doesn't come out. But if I don't talk about syndrome X, I won't be happy. Well, in your AKT, you know that medications used to treat type 2 diabetes is high yield. So I'm going to talk about all of them. The DPP-4 sitagliptin, the glyphosines, which are the SGLT2, metformins, both the modified release and the other types. I'm even going to talk about medication we no longer use. I'll mention them in passing. Acarbose is one of them. You need to know them. You need to know them. Poiglitazone, which is the tyrosine diones, you need to know them. Heart failure. So, my friends, tomorrow is thyroid alone is going to be, because you need to know the difference between MODY and type 1 is C peptide. So thyroid alone is going to take a long time. I don't know how I will do it, but I will do it tomorrow. I'm going to do it because you need to get every single question on thyroid, on diabetes. So if diabetes will take the whole time, so be it. I've done a bit of pheochromocytoma. In fact, I just thought that time when I was talking about pheochromocytoma, I should have just added the management and added the investigation. I know we've done it today. If acromegaly is going to be a problem, I prefer to discard it. You can read it on your own. But diabetes, I will never discard it, because what's the difference between Ditamir and Glargine? Many candidates don't know. They don't know. They are faffing around. When do you use insulin in type 2 diabetes? Some candidates, they have what we call insulin inertia. You need to know that terminology. The commonest question candidates may fail on medications used in management of diabetes is on GLP-1s, exenatide, liraglutide, because it's going a bit more technical. You need 2 points to start and 2 points to continue. My friends, I will say let's call it a day because there are too many things to know in endocrine. But it's easy, it's sweet. So they put a summary sheet here. In summary today, if you have joined us today, you would have seen that we've covered Addison's, and we've covered Addison's under a few points. We've looked at the picture. We've covered Addison's, we've looked at the investigation and diagnosis. We've covered Addison's, we've looked at the management. We've covered Addison's, we've talked about Addisonian crisis. We've covered Addison's, we've looked at sick day rules. We moved on to cover Cushing's. I showed you the picture. I played around with the picture, I shuffled it. I went back again to Addison's, I told you that they can ask it in any way and any form. Then I came back to Cushing's again, we looked at the types. I told you in Cushing's, there's the doctor Wahala, the doctor that is always giving steroids for a long time. In Cushing's, I told you there's the adrenal problem, which is what we call the renal or kidney Wahala. I went on to tell you that sometimes an adenoma in the brain can be the problem. I called it the brain Wahala. I say sometimes it can be an ectopic ACTH. I called it the lung Wahala. Again, we looked at the investigation and diagnosis. I told you the difference. The dexamethasone suppression test is to Cushing's, a short synactin test is to Addison's. Again, I said a 9 a.m. cortisol is to Addison's, as 24-hour urinary cortisol is to Cushing's. We looked at the management. I told you the indications for surgery, medication, including ketoconazole. My friends, we went to cones. I showed you the different pictures of cones. I told you the differences between primary and secondary hyperaldosteronism. Them is aldosterone. I went on to the investigation. I told you the first line is different from the second line. I told you CT scan, MRI, CT angiography, they are never first line. First line is always your renin aldosterone ratio. You need to know it. We went on to the management. I told you it can be surgery, but I told you that if it's not surgery, the popular first line is always aldosterone antagonist. I give you an example of aldosterone antagonist. I told you spironolactone. I give you another example. I told you eplerenone. My friends, I went on to hyperthyroidism. I told you about primary hyperthyroidism. Before I went to primary hyperthyroidism, I gave you a bit of a background. I gave you what we call pathophysiology. I went to secondary hyperthyroidism. We dissected and played around with it. I went to tertiary hyperthyroidism. I told you the same with primary. It's just that it's a continuation of secondary. I use the CAPP or the CPP rule to teach you hyperparathyroidism. My friends, I went on to thyroid disease after the break. I couldn't do so much. It's painful that we couldn't finish thyroid disease, but for purpose of summary, we looked at hypothyroidism. We looked at the picture which you already know. We looked at the treatments in primary care. We looked at the reasons or indications for referral to secondary care. We looked at subclinical hypothyroidism, and I compared it with subclinical hyperthyroidism. Before we even started this, I went into details of the interpretation of thyroid disease to you. I told you that a woman that is vomiting with abnormal TFTs can be two things, and you guys have looked at the ways it can come in the AKT. I told you about thyroid peroxidase antibodies. I went to town with it. I dragged you to know about Hashimoto's. I dragged you to know about Graves' disease. I brought in postpartum thyroiditis in a way that you can never fail it in the exam. Then I went to painful goiter to rest there. I told you Dequaviance is a cause of painful goiter. I told you amiodarone is a cause of painful goiter. But I forgot to tell you the causes of painless goiter. So I went back to tell you that Hashimoto's is a cause of painless goiter. I said Graves' disease is a cause of painless goiter. I now went and said Riddle's disease, which is one thing I forgot, which causes a hard, fixed, and painless goiter, is a cause of hypothyroidism. My friends, I went on again. We talked about hyperthyroidism management. I talked about carbimazole. I mentioned the two types of systems we can use. I talked about a bit about propylthiouracil. I told you about radioactive iodine. Then I went on to talk about thyroid storm, and we ended playing with thyroid cancer and thyroid eye disease. Don't fail any of these questions in the exam. It will be unfair to me. It will be unfair to this effort. It will be a waste of time. The 3-4 hours you spent this morning. If you failed any question on that, you would have wasted your time. You should have been watching a movie by now, or maybe reading, if you know that you feel a question on these things that we've talked about. Don't forget, iron within 4 hours of use of levothyroxine is a no-no. I beg you. I beg you. Don't forget, progesterone and androgens are also a cause of hypothyroidism, while testosterone and estrogen will be a cause of hyperthyroidism. So that's the summary of what we did today. I want to give time for questions. If you've got any question, please ask quickly.
Nick, I just want to confirm what time are we meeting this afternoon, please? And thank you for a
So I
very
think the
brief.
time is on the timetable. I think the timetable, I'm not sure. Is it usually 2 o'clock or 2:30? But there's a timetable on the group. Are you on the group?
Yes, I'm on the group, but I don't think there's a timetable for.
The timetable was sent, I think, 3 days ago. The timetable is always sent within the week. If you scroll to the classroom, you will see a colored. It always details what we'll be doing on the weekend, and you tell you the time. It's there. It's there. So it should be 2 o'clock. But if it's not 2 o'clock, does anybody know the time? And anybody can look at the timetable and just tell us the time so that we're sure. I don't want to give you a wrong time. It's usually that 2 o'clock or 2:30, depending on if we have RCA classes.
I've just checked that. I don't think that was sent. The one that was sent was for last weekend.
Okay,
Mm.
okay. It will be 2 o'clock. It will be 2 o'clock if it wasn't sent within the week. 2 o'clock. So 2 o'clock. Let's make it 2:30 because we've gone past this time.
That's what
Let's make
I'm
it
thinking. So we should
Yeah,
carry
okay,
it a little.
fine. Let's make it 2:30. And what I'll do is I won't keep you beyond 1 hour. Because I know if I say 1 hour, I'll do 1 hour 30 minutes. So let's just say I won't keep you beyond 1 hour so that maximum 4 o'clock we can go in case there's anything else. But again, we are not doing endocrine, we're just doing other high yield stuff. So yes. Any other question? Okay. If there's no question, everybody's happy. I think we should go and rest. So you guys should get some nice lunch. It's quite a lot of information to play around with, especially if you don't know some of these things. If you know some of these things, it's quite a lot of information to be reminded about. But it's a challenge. My teaching style is a challenge to people. So you see the other teachers, some of them teach in different styles. We've all got different styles to complement the students. But my own teaching style, I like to challenge you because if we keep tapping you on the back and saying you are doing well, you may pass and get 70, but that's not what I want. I want you to score 95. So each time you are doing well, I say, well, that's good, but you can do more. And that's because I know you can do more. So I always tap you on the back and say, well done, but do more. Each time you do more, I tap you again. I say, well done, but do more. Each time you do more again, I tap you. I say, well done, but do more. So you can always do more. Don't think, oh yes, I'm prepared. And everybody that thinks they are prepared, if your friend says, yes, I'm prepared for the AKT, tell them to come for our mock. Come and do the mock. If you pass the mock, then we can tell you that you are prepared. We will basically send your report and tell you in a few words that you are prepared. Otherwise, if you are not passing the mock very well, you are not yet prepared. And in October, when the mock comes up, you now need we need to see those mocks. We need to see, in fact, it sometimes triggers us to call a candidate and discuss with them. So please and please, let's go and rest. Let's take some time out and then we'll come back and have